Hepatorenal syndrome, please. Hepatorenal, you know what we are doing, right? Maybe it must be down, and it must be down. We are doing this. Let's finish. I think a marathon, because we shall prosper. We don't give up. That's why it's very good to understand. That's why you can still faith without any encouragement. Even in the midst of an impact here, you will still what? Have what? A clinical pregnancy. Alright, that's the one. When we talk about hepatorenal syndrome, okay, hepatorenal syndrome is liver cirrhosis plus ascites plus renal failure if all other causes of renal impairment have been excluded. Is that clear? So hepatorenal syndrome in short is what? Liver cirrhosis plus what? Ascites plus renal failure. If all other causes of renal impairment have been what? Excluded. If all other causes of renal impairment have been excluded. If all other causes of renal impairment have been what? Excluded. Is that clear? Yes. Now, let's talk about short pathophysiology. So, we will say that abnormal hemodynamics. Abnormal hemodynamics causes splanchnic and systemic vasodilation, but renal vasoconstriction. So abnormal hemodynamics causes splanchnic. We know what splanchnic is, right? Internal organs and systemic vasodilation, but renal vasoconstriction. It means that everything is dilating except that of what? The kidney. Is that clear? And if blood supply is not going to the kidney, what's going to happen? They're going to have renal hyperperfusion and the function of the kidney become what? Impaired. Is that clear? Is that clear?
Yes.
Now the question is, what accounts for the splanchnic vasodilation? Yes, Kennedy. What account for this? No. It should be accounted for by bacterial translocation. Okay? Bacterial translocation, cytokines, and mesenteric angiogenesis. So the splanchnic vasodilation is accounted for by what? Bacterial translocation, cytokine, this is an inflammatory mediator, and what? Mesenteric angiogenesis. Is that clear? Is we getting that? Yeah. Then the question is, what to account for the renal vasoconstriction? Yes. Kennedy. Kennedy, what to account? Yes. Patrick. Excellent. Abnormal autoregulation. That's correct. Abnormal autoregulation. Is that clear? Is that clear? Yes. Now let's look at the types of hepatorenal syndrome. Short, we are done. We are not done yet. So the types of hepatorenal syndrome. This is how I can mean here. So we have said renal vasoconstriction is accounted for by what? It's coming as a result of abnormal autoregulation. Now, let's talk about the types of hepatorenal syndrome. There are two types. We have hepatorenal syndrome 1. Okay, hepatorenal syndrome type 1. Hepatorenal syndrome type 1. Okay, this one will say that it's a rapidly progressive deterioration of circulatory and renal function. Rapidly progressive deterioration of circulatory and renal function. Okay? Now, for this, the mean survival or the median survival is less than what? 2 weeks. So if a patient has hepatorenal syndrome type 1 and nothing is done about it, it's allowed to take a NAPA course. You know NAPA course is if no intervention is applied, then the patient has less than 2 weeks to detect. Are we following?
Yes.
Are we following?
Yes.
Treatment. Can use what? Medical. Telepressin. Telepressin sounds like what? Vasopressin. What is it going to do? It will what? Patrick? Increase blood volume. Excellent. Increase blood volume. Reducing what? Hypovolemia. That's correct. Because the kidney needs blood. Hypovolemia will cause what? Pre-renal. It will constitute a pre-renal cause of what? Acute kidney injury. It will constitute a pre-renal failure. It will cause a pre-renal failure. Exactly. Are you following? Then another alternative is what? Hemodialysis. The last time we spoke about the indications for hemodialysis, true or false? Okay. When we use the valves, remember? Okay. Type 2. So type 2, we'll say that is what? Steady deterioration. Steady. It's not rapid. Steady deterioration of what? Renal function. Okay? Renal function. For this, the median survival. Yes, Patrick?
6 months.
Yes, it's equivalent to what? 6 months. Treatment. For treatments, we'll go with the first option. We can go with what? TIPS. TIPS stands for what? Transjugular. Intrahepatic. Orthosystemic. Continue. Orthosystemic stent shunt. Orthosystemic stent shunt. Orthosystemic shunt. Then we can also consider hemodialysis. Okay. Let's move towards the portal hypertension. From there, we look at the clinical storage system. Portal hypertension. So portal hypertension is said to occur when portal pressures, when portal pressures exceed 10 milliliters of mercury. When portal pressure exceeds 10 milliliters of what? Mercury. Please, are you getting that? When the portal pressure exceeds 10 millimeters of what? Mercury. This is that clear. The normal portal pressure will be equal to 5 to 10 millimeters of mercury. Is that clear? Is that clear? Are we following? Yeah.
Yes.
Now, let's move on. Let's talk about esophageal varices. Esophageal varices occur when the total pressure exceeds 12 millimeters of what? Mercury. Are we following? Are we following? Now, which we've done the surgery already, right? So, it has been done. We need to do. Okay. Now, let's look at the treatment of esophageal varices. How do we treat them? So, the first one is what? Endoscopy plus band ligation. The next one will be what? The use of what? Octreotide. What is octreotide, Kennedy? Huh? It's a what? It's okay. It's a somato analog. Yes, that's correct. So octreotide plus what? Tranexamic acid. Tranexamic acid. These are to stop bleeding. They kind of obliterate blood flow. Okay. Octreotide and what? Tranexamic acid. And the third one is what? Blood transfusion. In esophageal varices, initially, okay, if you want to reduce the bleeding, if the bleeding is not massive, you want to reduce it, we could also use what we call a sense-taking Blakemore tube. Okay? Sense-taking Blakemore tube. Sense-taking Blakemore tube. And also we use Blakemore. Sense-taking Blakemore tube. Sense-taking Blakemore tube also we use. It has, you fill it with air, and it has a balloon which will compress against the walls of the esophagus, creating a tamponing for the vessels. And that reduces what? The blood flow. Is that clear? Yes.
So, can you give antihypertensive?
For which one?
For
For that one, you only do it. See, you only give beta blocker when the bleeding has what? Resolved. If bleeding resolved, you can give a beta blocker like propranolol or metoprolol. Propranolol to reduce what? The blood pressure further. Is that clear? Yes.
It's mistaken Blakemore tube, but isn't it now rarely used in
Yes, that's why I didn't really get it. Because it's something more conservative. They're trying to reduce the amount of blood flow whilst you go for the alternative, you go for the definitive endoscopy treatment. Yes, to repair. Okay, let's move on. The other one, ascites, we spoke about ascites. We talked about apple medusa already, right? All right, that's fine. Now let's look at the clinical scoring system. We are moving the clinical scoring system. So for the clinical scoring system, there are two of them. Okay, we will look at the first one. That is Child-Pugh score. Child-Pugh score. So the Child-Pugh score is a clinical scoring system. It's a clinical scoring system. Child-Pugh score. Child-Pugh score is a clinical scoring system used to determine the severity. The clinical scoring system used to determine the severity. Clinical scoring system used to determine the severity. Prognosis. Used to determine the severity, prognosis, and peri-operative mortality of abdominal surgeries in a chronic liver disease patient, in a CLD patient. Clinical scoring system used to determine the severity, prognosis, and the peri-operative mortality of abdominal surgeries in a chronic liver disease patient, a CLD patient. Is that clear? Is that clear? Now let's look at the score, the components and the the parameters or components. So we are talking about the score. So the score we have 1, 2, 3. The lower the score, the better. I mean that. The lower the score, the better. The higher the score, the worse. I mean that. The lower the score, the better. The higher the score, the worse. Exactly. Now the parameters. The first one will take bilirubin, and the unit micromole per liter. Okay, micromole per liter. Bilirubin, the unit micromole per liter. So bilirubin levels are supposed to be low, right? So if you have bilirubin less than 34, we'll say that okay, that is good. So we'll give a score of 1. Okay. If you have a bilirubin level ranging from 34 to 51, that is getting worse. A score of what? 2. If you have greater than 51, give a score of what? 3. Are we getting that? Are we following?
Yes.
Then the next one, we are talking about albumin. The unit will be in gram per liter. So for albumin, if the albumin level is high, we are happy. Okay? But if it's low, then it's bad. If you have an albumin level of greater than 35 gram per liter, good. If it's decreasing 35 to 28, it's getting worse. If it's further decrease, it is worse. Is that clear? Is that clear? Sorry, less than. Thank you. Less than, yes, less than. Less than, further decrease, less than 28 gram per deciliter. The next one, prothrombin time. This one is going to be in seconds, or we can also think of what? INR, International Normalized Ratio. Okay? So we are going to have 2 things there. So if you are using a prothrombin time, it's going to be in seconds. The unit is going to be in seconds. Okay? INR does not have any units. So for prothrombin time, if you have a prothrombin time of 1 to 3 seconds, that is good. 4 to 6 is getting worse. Greater than 6 is worse. Is that clear? If you are using INR, you can use INR in place of prothrombin time. Because if you do clotting profile, the 2 parameters will be there. Okay. If you are using INR, if you have less than 1.7, it is good. If you have 1.7 to 2.2, it's getting worse. If you have greater than 2.2, it is what? Worst. Is that clear?
Yes.
Then we go to the next parameter. That will be ascites. For ascites, no ascites, you give a score of 1. That is a good thing. If you have a mild ascites, if I say a mild ascites, it means the ascites responding to a medical therapy. Then if you have moderate ascites, in that case, another form that we can put it, we can say that an ascites that is refractory to medical therapy. Okay. Then the last parameter will be hepatic encephalopathy. That is why we look at the grades, because without that, we cannot talk about this score. No encephalopathy, that is good, we give a score of 1. Encephalopathy grades 1 to 2, it is getting worse. Grades 3 to 4, that is worst. Is that clear? Is that clear? Yes. Now let's interpret quickly. Interpretation. So the interpretation, I'm going to put it in the form of a table again. So the first one is the total score. Are we following? Total score, the class that they belong, the lifespan, how long are they going to live? Then the last one is the perioperative abdominal cell mortality. So with this, if you have a score of 5 to 6, then we'll say you belong to class A. You belong to class A, you will live. You should be able to live for what? 15 to 20 years. Are we getting that? Are we following? Then your perioperative mortality should be very low, it should be 10%. If the score is 7 to 9, then we'll say you belong to class what? B. And you should live for what? 4 to 14 years. And your perioperative mortality will increase. It will go to what? 30%. Then the last one, if the score is 10 to 15, well, the total score should be about 30 by 5, which is 15. Then you say that you belong to class C. You will live less, 1 to 3 years. And your perioperative mortality will be the highest. That's 82% thereabout. Is that clear? Is that clear? Please read that. Read that.
Yes.
This is the interpretation. Total score of 5 to 6, class A. Lifespan 15 to 20 years. Perioperative mortality 10%. Total score 7 to 9, class B. Lifespan 4 to 14 years. Perioperative mortality 30%. And class C will be what? 10 to 15. Perioperative mortality 82%. Lifespan will be 1 to 3 years. Is that clear? Now, let's look at the second score. Then we are almost done. The second score will not talk into detail like this. We call it the MELD score. MELD score stands for model. That's M for end stage liver disease. So MELD, okay? Model for end stage liver disease. MELD, model for end stage liver disease. MELD score. Is that clear?
Yes.
This one we just talk about the component and that's it. Okay? Components. Component you can remember by saying that DB6. Okay? DB6. So the component, the first one, we will say dialysis. Dialysis for at least twice. At least twice. Dialysis at least twice. At least twice in the past week. In the past week. Or continuous venous hemodialysis. Continuous venous hemodialysis for at least 24 hours in the past week. So either this or this, okay? The second component is the bilirubin. The next one, they are talking about creatinine. The next one, INR. And the last one is sodium. Exactly. Exactly. Please really understand.
Yes.
It has been noted that if you use only the Child-Pugh score, you may not get the true, the sensitivity is low. But if you add the MELD score to the Child-Pugh score, the sensitivity is what? High. Exactly. But this one, I mean, it's a calculator. So depending on what you are getting, you have the score. Exactly. All right. The last thing we'll talk about is the management of chronic liver disease. Management, how it is. So you are done. That's the last thing. You are done. The next 2 to 5 minutes should be done. Done very well. That was a very solid marathon. Yes. From 7 to good. That's a good one. That's the more reason why you must prosper at all costs. Because you have sacrifice. You cannot sacrifice and expect failure. Yeah. All right, let's move on. Management. Management of chronic liver disease. So right, admit, assess airway, breathing and circulation and correct disease. Admit, assess airway, assess ABC, that's admit, assess airway, breathing, circulation, admit, assess airway, breathing and circulation and correct deficit. Admit airway, assess airway, breathing and correction. Admit, the spirit is very good. Let them know. If it goes there, it will be all nice. Yes. Alright, let's move on. So we say admit, assess airway, breathing, and circulation and correct disease. Okay. Check random blood sugar and correct hypoglycemia if any. If present, and correct hypoglycemia if present. Check random blood sugar. Check RBS and correct hypoglycemia if present. And that's one. IV 1 liter of 5% dextrose. The one that we wrote, remember, IV 1 liter of 5% dextrose. IV 1 liter of 5% dextrose plus pampriness 1 and what? 2, 8 hourly. Please, are you following? Are you following? Yes. And next one. The next thing. Serum lactulose 30 to 50 ml 8 hourly. Serum lactulose 30 to 50 ml 8 hourly. Plus, so you put into bracket. Put into bracket. Plus vitamin K injection. The reason why we are saying vitamin K injection, you know why? Because you see, the gut flora is responsible for the production of new vitamin. Vitamin what? K what? K2. Okay. And which gut flora are we talking about here? Bacteroids. Okay, bacteroids. Okay. Is are you following? Yes. Okay. They can produce vitamin K2. Vitamin K2 is also known as what? Menaquinone. Vitamin K1, which is from plants, phytoquinone. Vitamin K3, which is synthetic, is known as what? Menadiol. Exactly. Alright, so if you are giving serum lactulose, remember, the acidic medium created by the lactulose is killing the gut flora. So the synthesis of vitamin K2 becomes suppressed. So that is why vitamin K injection may be needed in this case. Is that clear? Yeah. Is that clear? The next one, request for an urgent head CT scan to rule out. Request for an urgent head CT scan. Request for an urgent head CT scan to rule out subdural hematoma if patient is an alcoholic. So that's it's a clause. It's not a must. Request for an urgent head CT scan if patient is what? An alcoholic. So again, let's move back a bit. The reason why you are giving serum lactulose here, if there is no hepatic encephalopathy, is to prevent the hepatic encephalopathy. And if the hepatic encephalopathy is even present, it's what? Reduce the level of what? Circulating ammonia and improve the condition. Is that clear? Please, are you following me? Yeah. The next one. The next thing that we are going to say over there is going to be dependent if so and so is present. So in this case, we are going to be guiding against what? Spontaneous bacterial peritonitis. Are we getting it? So in this case, if you are guiding against this, what are we going to use? Yes. If there is no spontaneous bacterial peritonitis, you want to keep prophylaxis. So in that case, we are going to what? we'll give what antibiotics to guide against what spontaneous bacterial peritonitis. And in that case, we'll use what ciprofloxacin. But if there's spontaneous bacterial peritonitis, that one will use what tazobactam piperacillin or piperacillin tazobactam. Then that's why you monitor the vitals, sweet vitals, the blood pressure. Which one? Specifically. Which one? Yes, I said antibiotics into brackets ciprofloxacin to guide against what spontaneous bacterial peritonitis. Okay. The next thing I said we should monitor vitals, 3 vitals, blood pressure, pulse, respiratory rate, temperature, and what SpO2, oxygen saturation, SpO2. Yes.
What about random blood?
Is that?
What about random blood?
Well, we said that already. We said that already. Long time. Then the last thing is treat the underlying cause. Treat the underlying cause. Treat the underlying cause. So for the underlying cause, if it is example, we can give one example and do that. So if the underlying cause, pay attention. So we treated most of the underlying cause already. Like the Wilson disease, we talked about that. So we just take chronic alcoholism, only that one. If the underlying cause is chronic alcoholism, what are we going to do? So it means like in this case, patient should be given thiamine. What is thiamine? Okay. Patient should be given what? Oral thiamine. Okay. Oral thiamine, that's vitamin B1. Okay, how much? 100 milligram daily. Okay. The patient should also be given what? Chlordazepam. Chlordazepam to guide against what? Withdrawal symptoms. Okay. Chlordazepam to what? Prevent alcohol withdrawal. Yes, are we following?
Yes.
To prevent alcohol withdrawal. But chlordazepam, this is how it's given. You can use it like this. 20 example of a regimen: 20 milligram twice daily. Okay, for 1 week. Then you taper the dose. 10 milligram daily for another 1 week. Then you go to 5 milligram daily for another 1 week. Then you stop. Are we getting that? Are we following?
Yes.
Chlordazepam, you don't give it the same dose for long period of time. You taper the dose. Are we getting that?
Yes.
Are we getting that?
Yes.
So for alcoholics, this is what you are going to do. Yes.
The first 20 milligrams
No, and let's give an example. You can use it for a week. Then the next week you taper. You can go weekly. Please, are we getting that? Are we following?
Yes.
Okay, so that's one of the examples. If we take for example Wilson disease, we know how to penicillamine or trianine. We said that, right? All right. Yes. Go ahead.
Synthesis, like the active therapy and I didn't say anything because I think
Is it vitamin C? What's the function of vitamin B? So it has several families. That's just one family. There's another family like without doing that. Are you getting it? And if you are talking about chronic disease, it doesn't mean that there's absolute efficiency of chronic practice. There's going to be a difference. So the ones that are there, vitamin B should go and help synthesize. Are you getting that? Please. Any questions? All right. Thank you very much. Yes.
So these are patients, the general treatment, very silence. The treatment of the patient, very immune coverage.
Yes.
Government has time.
Yes.
So if it's
So that one is not going to be forever. How do you for 24, 48 hours? Then you stop. Those will continue. All right. So thank you very much for that persistent. Persistence. For that persistence, you have done so well. I'm very happy. Myself, I'm happy. And you have been able to achieve what you wanted to do. My wish is for you to revise and revise and become the revising. Thank you very much for your attention and have a blessed evening.
Thank you.